Hello, good evening, everybody. This is April 23rd, and this is the date when we scheduled the webinar entitled The Pseudoparalysis Dilemma. I think it's a very interesting topic of which there is a lot of controversy, and trying to have a good debate on this difficult topic. We have the participation of 4 masters in this specific condition. First, Maristella Saccomanno from Brescia, also Ruth Delaney from Dublin, Kany from Toulouse, and Alexandre Lädermann from Geneva, all of them very well-known, renowned shoulder surgeon. Feel also free to send questions and remarks about the presentations, and let's go to the topic. Our first speaker was Giuseppe Milano. He cannot be available, but Maristella is taking over him, and she will address the difficult topic, how to explain and how to predict pseudoparalysis. So please, Maristella, go ahead.
Thank you very much once again, Emilio. So I'm sorry, but Giuseppe Milano couldn't be here, so I tried to give his talk. So what is the pseudoparalysis? How can we define the pseudoparalysis? So I'd like to start with this study, which is a very small survey among 15 shoulder surgeons in US, and the results are pretty funny, actually. They were asked to observe 18 different patients, videos, imaging, and to agree on the diagnosis of pseudoparalysis. And the results were very interesting because basically there was a minimal agreement on diagnostic criteria of pseudoparalysis. There was no agreement at all on the severity of pseudoparalysis. And guess what? Half of the surgeons just thought that pseudoparalysis and pseudoparalysis are basically an identical clinical condition. So I think it's very interesting starting point. So let's take a look to this woman and try to understand if really pseudoparalysis or pseudoparalysis are really the same thing, an identical clinical condition. If we look at the literature, we're going to find several definitions when we talk about pseudoparalysis. First, the first focus is the active elevation. So an active elevation less than 90 degrees, less than 60 degrees, less than 45, or 0 degree of active elevation. These are all definitions of pseudoparalysis when you look at the literature. So this is the first controversial point. We all agree that the full passive elevation, the full passive motion is maintained because basically there is no neurological impairment on the basis of this pathology. Pain is considered a confounding factor to distinguish between a true pseudoparalysis or a pseudoparalysis and shoulder that cannot be moved, mainly because of pain. But this is only the beginning. Another point of discussion is anterior superior escape during elevation, but also is reflected also when you look at the imaging, when you look at the MRI. And the setting, the onset, is an acute onset or chronic onset. As we know, the majority of massive calf tear that we see very painful and with a pseudoparalytic or pseudoparalytic shoulder, we're going to try to find a real definition, are a sort of acute and chronic. So we already have a big tear, but now we have a massive tear related to an acute event. So I think this table is very, very clear and very important to be looked at. So we talk about pseudoparalysis when we have an active forward elevation less than 90 degrees, basically. And we talk about pseudoparalysis, but when we are not really able to elevate our arm at all, once again, pseudoparalysis can be also found just removing the pain contributing factor. Basically, an injection of lidocaine solves the pain, and we can evaluate the patient once again and distinguish if it's a real pseudoparalytic shoulder or only is a pseudoparalysis. But the deficit can also be found in external rotation or internal rotation, and we need to make the same distinction basically between pseudoparalysis we're going to learn pseudoparalysis is something we can revert by the end of the day, and pseudoparalysis, true pseudoparalysis, is something we cannot revert, and we're going to learn why in a few moments. So when we talk about a real deficit in external rotation, we're going to talk about pseudoparalysis when we have a lagging back to neutral, and the pseudoparalysis when it goes to -40, as an example. So let's try to explain what happened. Why do we have a pseudoparalysis? Basically, we know that the main role of the rotator cuff is to be a dynamic stabilizer of the humeral head. So if there is a disruption in the rotator cuff, probably you have a sort of glenohumeral instability, which means that the humeral head is risk to be decentered, basically. So one of the first explanation was that pseudoparalysis required the disruption of at least one rotator cable attachment. So it means that there is an insufficient centralization of the humeral head on the glenoid. But main contribution to understand what pseudoparalysis is and which are the predictive patterns was given by Philippe Collin in 2014 with this classification. Basically, he highlighted the important role of subscapularis tendon and teres minor. So he divided subscapularis in the upper part and the lower part, and he told us that when you have a complete involvement of the subscapularis, or when you have an involvement, a big involvement of the upper and lower part, with the fat infiltration, with advanced fat infiltration, or the generation of the subscapularis tendon for the anterior superior tear, and for teres minor, when you look at the posterior superior tear, then you have a high risk of pseudoparalysis, of true pseudoparalysis, so something you cannot be reversed. And the shoulder equator concept is pretty similar. So basically, the equator line is in the center of the humeral head, with the perpendicular line to the humeral axis. And it can be seen in the vertical plane or in the horizontal plane. And once again, just confirm what we already learned from Philippe Collin. If you have an involvement of more than 50% of the subscapularis tendon with severe fat infiltration, then you have a high risk of pseudoparalysis. So odds ratio was calculated by 5. Similarly happen when you have a global tear, so involving anterior and posterior part, or when the teres minor is involved, so below the equator line, as you can see in the picture. And this is another interesting study talking about prediction of pseudoparalysis, probably a little bit more complicated to understand at the first look, but the concept is always the same. Pseudoparalysis means insufficient centralization of the humeral head in the glenoid, which can be the case, the cause of the anterior superior escape, of course. So in this case, looking at an X-ray, basically you have two concentric spheres that define the shoulder abduction moment. So the first sphere, the smaller one, is around the humeral head, which means that describes the rotator cuff. So the ratio between the radio of the rotator cuff, the humeral head, and the deltoid muscle, which can be drawn by drawing a line through the acromial line, define the shoulder abduction moment. The higher is the shoulder abduction moment, the higher is the glenohumeral stability. On the opposite, when you have a shoulder abduction moment inferior to 0.77, the risk, the odds ratio to get a pseudoparalysis goes up to 11. So that's a nice chance to have a pseudoparalysis. Last but not least, we already said the onset, the timing. So true pseudoparalysis is usually a chronic tear because you need a sort of irreversible situation when you have fat infiltration over 3, so very degenerated, and an anterior superior escape, a dynamic anterior superior escape, but also static sometimes. That can be seen at the MRI. Of course, this is going to influence the treatment. So I would say that pseudoparalysis is still a reversible situation, and so we can treat it by rehab, by eliminating the forescapula, because we still have part of the teres minor, we still have the teres minor and at least the lower part of the subscapularis tendon. Joint preserving options are important in this situation because eliminate the pain or reduce the pain and also reduce the tension on the subscapularis and the teres minor. And of course, the replacement is still an option even in a pseudoparalytic shoulder if there are any degenerative changes. On the contrary, if we get a true pseudoparalysis, so the humeral head cannot be recentered by doing a partial repair of the rotator cuff or any other joint preservation option, then the replacement is probably the only option. Is there a role for a tendon transfer? We're going to see in the next presentation. I would say, of course, when we have a combined active external rotation deficit, as you know, I'm a big sustainer of SCR and a lower trapezius transfer in this case. For the true pseudoparalysis, this is another topic of debate, actually, because some people say that it's enough if you just lateralize your replacement. Others say that it's not. So in the end, I think that pseudoparalysis and pseudoparalysis are two different entities. Pseudoparalysis is a sort of reversible entities, so you need to eliminate the pain, but the humeral head is still centered. True pseudoparalysis is a chronic situation, almost irreversible. How to explain the pseudoparalysis? Basically, what happened is an irreversible forescapula imbalance. Thank you.
Okay, Maristella, thank you very much for making so clear these concepts. It's interesting that all the information we have about among surgeons about what they think that is pseudoparalysis, there's not very good concordance among them. So it's very important to try to follow the same definition to test treatments and to understand our patients. Our next speaker is Kany from Toulouse. Jean is highly experienced in tendon transfers, and he will talk about both tendon transfer and superior capsular reconstruction to treat pseudoparalysis.
Okay, thank you, Emilio, for the introduction, and thank you, Maristella, for the invitation. So this topic is really difficult, and I had to work very hard to try to understand how I can explain easy this topic. So I have no conflicts of interest for that. First of all, you know that we know since 1988 that we have a starter in the shoulder and you have the stabilizers of the shoulder. And what happens if you have no deltoid but an active cuff? Finally, you have a normal active range of motion because you're stable, your joint is stable. And theoretically, surgery is not mandatory because your shoulder have a normal range of motion, a normal function, but maybe a little weak, but normal. If you don't believe me, look at this patient who, after a post-dislocation axial nerve palsy, he has no deltoid, but he has a normal curve. And you can see he has quite normal range of motion. He has a weak shoulder on the left side, of course. There is no deltoid, but normal range of motion. And again, in this patient, there is no really indication, except if you want to recover really the deltoid to become stronger. But the question is still open. On the opposite, you should know that when you have no cuff but an active deltoid, the problem is totally different. You have loss of active range of motion in one or two directions, but in that situation, you could say, okay, I will propose a dynamic transfer to balance the shoulder. But the story doesn't stop here. Look at this paper since 1974, because at this time they use a lot of tendon transfer, especially in the end. There are different rules of tendon transfer, and one of the main rules is the joint must be stable. I repeat, the joint must be stable. So that means an unstable joint cannot be transferred as well. So let's go back. No cuff but active deltoid. You have no loss of active range of motion in one direction, but deeply, fundamentally, you may have an unstable shoulder with a superior escape. So if you have this situation, first of all, number one, you don't have to transfer, you have to stabilize the joint. And second, if you are able to stabilize the joint, then you can do a dynamic transfer to balance the shoulder. Look at this example. It's a combined loss of elevation and internal rotation. So per se, for me, it's the pseudoparalytic shoulder. If we follow the presentation of Maristella, there is an unstable shoulder. It's the same definition. In this example, there is a dynamic anterosuperior escape of a shoulder. So it is unstable. It is a pseudoparalytic shoulder. It's, for me, a synonym. So for sure, you know that with Philippe Collin, when you have an anterior escape of a shoulder, when you no subscap more than 50% and no supraspinatus, the rate of having a paralytic shoulder, a pseudoparalytic shoulder, is 88%. And it is an unstable shoulder. You lose your vertical and horizontal balance of the shoulder. On the contrary, when you have no supra, no infra, and specifically no teres minor, like said Maristella, I totally agree with that, you may have, but only in 33% of the cases, you may have a posterior superior escape of the shoulder. It is already an unstable shoulder. Maybe the subacromial vault could preserve for a while this pseudoparalytic shoulder. This is the reason why maybe we don't have the same evolution. So when you have such a situation, what to do? The first question, is your shoulder vertically stable? Yes, your shoulder is stable. Okay, I think you can transfer, but if you transfer, you have to choose the best one, the best transfer. So if you want to get ER2, external rotation in abduction, the best total transfer is the lat dorsi, better than the lower trap. On the opposite, if you want to get ER1, the lower trap is stronger than the lat dorsi. So it depends what you want to do on your shoulder. And finally, if you want to get internal rotation, the lat dorsi is the little brother or the big brother of a subscap, and it is the best one to recreate, to recover internal rotation. So choose the best one. So now let's go to the first question. Your shoulder is not stable. Oh, please don't do a transfer. It will fail for sure. Just stabilize first. So now the question is how to stabilize the shoulder. Are you able to stabilize the shoulder? You are able to stabilize the shoulder, okay? So in that situation, you can stabilize first, and then you do your concomitant transfer. So how to stabilize the joint with soft tissue? Of course, we know Mihata with a superior capsular reconstruction. You can do it with an artificial graft or with a fasciolata for sure. It stabilizes vertically the shoulder, yes. But you can use the long head of the bicep if it is still present, because as you know, sometimes the bicep is absent. And you can make a bio superior capsular reconstruction with your bicep. You have lots of publication and lots of technique. So let's go back to the second question. You are not able to stabilize your shoulder? Okay, please reverse. You cannot work. It cannot work if you're not able. A tendon transfer cannot work. So remember this balance, and this is a rule. To have a balance, there is a rule between the length and the weight. In the shoulder, it's exactly the same, but the game is over. Look at, there is only 3 centimeters on the head, but 30 centimeters on the humerus shaft. So 1 out of 10, the game is over to elevate the shoulder. It's not the same if you want to external rotate. So when soft tissue are not able to vertical stabilize the shoulder, in case of pseudoparalytic shoulder like that, the only way is to medullarize the center of rotation to make a mechanical shoulder. So you just medullarize the center of rotation, you increase the lever arm of the deltoid, and then you can get elevation. This is the reverse shoulder arthroplasty. Okay. So I'm sorry for this sound, but I cut the sound here. So the last point I want to say is never do a transfer if you have a stiff shoulder. You see on the right of your screen, there is a posterior capsule retraction. There is no subscap, but posterior capsule retraction. It is a stiff shoulder. You are not able to have a good passive range of motion at your office, so the tendon transfer will never be strong enough to rebalance the shoulder. So on the left of your screen, you can see the same patient, not the same patient, but the same subscap tear, but there is no posterior stiffness. So then you can do a transfer. So, okay, finally, what is our algorithm? I use the classification of Pascal Boileau, and so you can see the isolated loss of elevation, the painful loss of elevation. You can see the isolated loss of external rotation, and you can see the isolated loss of internal rotations. There is only one direction of deficit, and your shoulder is stable vertically. In that situation, I use a tendon transfer, but today I enjoy augmented my tendon transfer with biceps superior capsular reconstruction to help my tendon transfer to work. And this is what I am doing today. I do my tendon transfer, but first of all, I do, if I can, when biceps is still present, I do a stabilization with a elongate of biceps, first to stabilize the shoulder, then I do my tendon transfer to fire and to balance my shoulder. And Maristella published this paper, very nice paper, where she proposed to make a lower top transfer in addition, in combination with a superior capsular reconstruction. I think it's a wonderful idea. It's logical because the one is not opposite to the other one. The one will just augment the second one, and this is logical. So finally, on the opposite, in case of pseudoparalytic shoulder, you may have no elevation less than 45 degrees. You may have a combination of loss of elevation or external rotation, a loss of elevation and internal rotation. It's a two-direction deficiency. There is a vertically unstable shoulder. There is nothing else than the reverse. So first stabilize, and then, of course, you can combine with a tendon transfer. So finally, to sum up, I think the supercapsular reconstruction, or in bracket, the reverse, can vertically stabilize the shoulder, but the tendon transfer can horizontally balance the shoulder. Okay, thank you very much.
Thank you, Jean. The more I hear you, the more I love your way of thinking, actually. So I'm always that's amazing every time. So speaker would be Ruth, and she will talk about reverse shoulder replacement in pseudoparalysis.
Thank you. Thanks, Maristella and Emilio and everybody at SECEC for putting it together, this webinar. It's amazing to see in the chat how many of you are tuning in from not just within Europe, but Central America, South America, India, California. So thank you everyone for being here. It's a really interesting topic because we just don't understand so much and we don't agree on things. These are my disclosures, some of which are relevant to the topic of reverse shoulder arthroplasty. So we've been talking a bit already about what is pseudoparalysis, and the reality is we just don't agree. And then we get into pseudoparesis versus pseudoparalysis, and Maristella really elegantly outlined some of the ways you can try to differentiate those two terms. It's important that we realize the differences between acute and chronic pseudoparalysis. We often see somebody who had a well-compensated chronic cuff tear, falls down, has an acute worsening of their cuff tear, and then they become pseudoparalytic, but it only happened, in the past couple of weeks. That's something that maybe we can still salvage versus somebody who hasn't been able to raise their arm for months or years. And JT Tokish has published a really good review in 2017 of how much variability there is in the literature of what we're talking about. And so all these variable definitions and debate amongst all of us, it's still a challenging condition for the patient to deal with. It's really limiting on their activities of daily living and their quality of life. They're really upset by not being able to raise their arm, even if it doesn't involve pain. But if we can't agree on what we're defining, then when we see people claim that a certain procedure reverses pseudoparalysis, then what do we mean? What are we starting at as baseline? And so if we have a condition pseudoparalysis, what are our options? Which ones are appropriate? Maybe in some situations, acute pseudoparalysis, it might be reasonable to repair the cuff or to do an SCR, maybe a tendon transfer, as Jean has explained, maybe combining them. Many people would still feel that tendon transfer is contraindicated when there's pseudoparalysis or lack of active elevation. And what where do we get to with the outcomes? We know that the reverse is a reliable way of restoring the ability to raise the arm. We published on SCR in our first 56 cases, our early experience with the SCR using the DX matrix xenograft from Arthrex. And within that series, there were 11 patients who we defined as truly pseudoparalytic, meaning that there was anterosuperior escape with attempted active forward elevation in the presence of full passive range of motion. And we did not find that the SCR could reliably reverse that situation. So out of 11 pseudoparalytic patients, 5 of them were able to raise their arm after completing their rehab post-SCR, 6 were not. We made a mistake, I think, in not really drilling down into which of them were acutely versus chronically pseudoparalytic, and that may have made a difference, because I do feel that some of the acute pseudoparalytics probably would have gotten better anyway. But the point is that in my hands, SCR does not reliably reverse pseudoparalysis, and the patients who were pseudoparalytic preoperatively had a worse subjective shoulder value, significantly worse at a 12-month follow-up than the ones who were not pseudoparalytic. So if we want to really reverse true chronic pseudoparalysis reliably, there's probably one reliable operation to do that, and that's the reverse. So we published our findings on the variability, similar to some of the studies that Maristella presented, the variability in what we actually call pseudoparalysis. And this was kind of fun to do. We sent videos to the membership of SECEC, of ASES, of our national society, which covers quite a lot of the world when you think of how many international members we have in, for example, in SECEC. And so we got almost 250 responses to the first survey. We did do it a second time to get inter and intra observer reliability, which was over 50 surgeons a second time. And these were shoulder experts based on experience and fellowship training. And when we asked people what they defined as pseudoparalysis in words, my favorite one was attempted active flexion causes anterosuperior escape, but the vast majority felt active shoulder flexion less than 90 with full passive range of motion. Now you could argue, is that pseudoparesis or pseudoparalysis? And then a similar proportion of people as chose the anterosuperior escape definition chose the definition of visible muscle contraction with no active flexion. And then just under 10% had a whole other definition with words. When we showed people videos of patients and said, just say yes or no, is this person pseudoparalytic? Surgeons were better at agreeing on that, except for this one outlier patient, number 7, where it was split pretty evenly. And this is what he looked like. I didn't think he was pseudoparalytic personally, but about half of the people did. He was a guy with a massive cuff tear that I ended up doing a repair for. And so it's interesting, we know that we're not very reliable in what we're defining in this term, but we're a bit better when we look at actual patient scenarios. The video bank intra-rater reliability was better than even the preferred definition. So we don't even agree with ourselves. If you ask somebody what they define as pseudoparalysis, and then you ask them again 3 months later, they don't even come up with the same answer. And that's why it becomes a bit ridiculous to even use this term, but it's already ingrained in our literature. So I think we're stuck with it. We probably are better on subjective interpretation of watching patients than actually explicitly defining, but we need to be careful when we use this term. So I think if you are publishing a study and you're talking about pseudoparalytic patients, you need to state very clearly at the outset what you mean. Maybe it would be better if we didn't use this term at all, but it's probably too late. This paper that Alex did with Gilles Walsh and Philippe Collin has been mentioned already this evening. Really important, the tear pattern, the subscap involvement. If there's complete subscap and supra, 80% of the cases were pseudoparalytic. Dysfunction of the entire subscap and supra or of 3 of the 4 muscles is a significant risk factor for not being able to raise the arm. And so again, we come back to true chronic pseudoparalysis. There's really, in my opinion, one reliable way to reverse it. So what's the debate then? So the concerns are, if you have younger patients who have true pseudoparalysis, 2 of the best arthroplasty surgeons in the world, Christian Gerber and JP Warner, have published sobering figures on when you do, for example, a reverse in a patient under 65, Gerber's incidence of complications was 38%. If you do a reverse in a young patient, the odds of having to revise that before the end of their life obviously is higher than in older patients. And Warner showed greater than 50% complication rate when you revise reverse to reverse. These papers are a little bit older, so maybe those implants are older. We didn't have preoperative planning. Are we better now at doing reverses? Have we gotten more comfortable with putting a reverse in a younger patient? The Mayo Clinic group published in a couple of years after those papers, good 2- and 5-year survival rates, 9% complication rate, 3% dislocation, patients under 65, not that different to the general sort of population of reverses Whether the notching was relevant or not clinically is debatable. But their point was that there were significant improvements in the patient-reported outcome measures without high numbers of early failures. And so it is a reasonable option, and it's less of a concern now to do a reverse in slightly younger patients. I think it's still a concern if we do it in patients who have heavy demands on their shoulder. Like in my country, farmers who are doing a lot of heavy labor, I worry about doing a reverse in them, for example. What does the literature tell us about reverse for pseudoparalysis? This paper from 2023 found that males with preoperative pseudoparalysis had quicker functional recovery than females, which is interesting, perhaps to do with strength. If we look at medialized versus lateralized humeral implant design, so a 145-degree versus a 155-degree implant, no significant difference in active range of motion, but the lateralized group seemed to have a quicker recovery. If you look at pseudoparalysis specifically, the vast majority of patients, all except one in the whole series, recovered from their pseudoparalysis with the reverse. Non-lateralized had higher complication rate and higher notching. But the point is that it worked either way. Medialized or lateralized humerus worked for pseudoparalysis in reverse. In this paper from 2021, is there an influence on pre-op disease? Is there an influence of the preoperative disease severity on the post-op outcomes? Actually, people who were worse preoperatively had greater satisfaction post-op. Pseudoparalysis did not mean that the patients were more likely to be in the worst outcome group or more likely to be in the dissatisfied group. So pseudoparalysis should not put us off doing a reverse. The factors that the group from Korea found that were associated with poor active anterior elevation were not related to pseudoparalysis, which again is interesting. So it doesn't seem to influence the post-operative outcome. What they found was that if you had an increased lateral humeral offset, that seemed to negatively affect anterior elevation, but this was in a prosthesis that was designed to be medialized. This was in the older Equalis type prosthesis. So I think there is an implant design dependent factor here as well. But the take-home message here was that there was no evidence of correlation between pre-op pseudoparalysis and post-op poor active elevation. So what do we do with a younger pseudoparalytic patient? It's easy when you have a 75 or 80-year-old person who's pseudoparalytic. It's no big debate that a reverse is a good option there. But if they're younger, what do we do? If I do an SCR in my hands, maybe a flip of a coin as to whether I can actually reverse their pseudoparalysis. Okay, we didn't really look at acute versus chronic. And I think there are probably functional factors in terms of copers and people who can manage to overcome pseudoparalysis versus not. So if we do an SCR in these people and they fail and are still pseudoparalytic, well, okay, can we just go and do a reverse then? I think probably, yes, we can. That's an option. My experience so far, and thankfully we haven't had a large number of SCRs that had to convert to reverse. We did not have any increased complications so far, but the literature would suggest that a reverse after a failed SCR has a poorer outcome than a reverse after a failed cup repair. There are two small series in the literature, each only have 13 patients. Gus Mazzacca did this one where he matched them with failed cuffs. There were more smokers and workers' comp cases in the SCR group, so that's a potential confounder, but the outcomes were worse after SCR. It doesn't specifically examine whether any of the patients were pseudoparalytic pre their SCR. Similar range of motion improvements, but their patient-reported outcome measures were significantly poorer across their pain scores and these other patient-reported outcome scores if they'd had an SCR before their reverse. Similar in this one other series, again, only 13 patients, it's small numbers, complication rate no different, but the outcomes were not as good after SCR. So I think a little bit of caution before we do SCR in a patient who's pseudoparalytic if we think that we'll just get the same result bailing out with a reverse. When we rehab a patient after a reverse for pseudoparalysis, I think we have to realize it's not the same as a reverse for somebody who's osteoarthritic and has good elevation beforehand, because there are long-standing muscle patterning problems that may take quite a while to overcome. And so a lot of training to eliminate scapular hitching. I like to have them start to do active assisted quite early. And if you lie them supine, the scapula is stabilized, and this sort of active assisted rehab that many of us learned in Lyon from Dr. Lyotard, who works with Dr. Walsh, can be quite helpful in this situation. As we have seen in the previous presentations, the lever arms matter and the physics, the biomechanics of the arm. You'll find that those heavier patients, they have a big, heavy arm. It's much harder for them. They will be slower. So I think we have to set expectations differently. We have to train the deltoid and use this sort of lawn chair supine program when we're teaching a shoulder to overcome pseudoparalysis, even after we've given them the mechanics to do it with a reverse. So the take-home message is, I think acute pseudoparalysis is a different thing. It may recover with time and rehabilitation. The SCR, in my opinion, does not reliably reverse true chronic pseudoparalysis. Tendon transfers don't. I'm not sure if the combination can, perhaps if the SCR can stabilize vertically, as Jean has said, but I think it's not reliable compared to the reverse. The functional outcomes are probably not as predictable after pseudoparalysis when we do a reverse compared to non-pseudoparalytic. It may take longer. We still should be a little bit cautious about implant longevity, but I think that age is less of a concern now with the reverse. Thank you.
We've been addressing the different, what is pseudoparalysis, different approaches, including SCR, tendon transfer, and reverse arthroplasty. But we all have some experience about patients. Oh, sorry. About patients that were treated with physical therapy and they improved their pseudoparalysis. So Alex, please let us know about the role of rehabilitation in the treatment of patients with pseudoparalysis and pseudoparalysis. Thank you, Alex.
Thank you, Emilio. I'm sorry, I'm a little bit ill and I just did a wine night, so I won't have the same energy as usual. However, I will do my best. So this is the question that I need to answer, and I have to admit that you already heard a lot about it. But I think that in order to have this deep imbued in your brain, you should listen to this presentation because it will probably summarize everything that has been said previously. I'm full of conflict of interest, but none regarding this presentation. So the conservative treatment, you know, when somebody come to see you because he has either a pseudoparalysis or a pseudoparalysis, he's waiting for a serious proposal. And it's always quite difficult to look at this patient and just to say to him, I'm sorry, sir, but I'm not going to operate on your shoulder because you have a high chance of success to recover anterior forward flexion with simple physiotherapy. Most of the patients don't believe you, and one of the reasons is because they already saw another surgeon that proposed a surgery. So this presentation will try to summarize the 16 publication that Philippe and I and Patrick Donat did about this topic. And the one in blue is probably the most important one. You have to know that the last one written by Kany also included Ruth. So I would like to give you my definition of a pseudoparalysis. What is the problem? I would like to go then back to the basis and to summarize how I treat an irreparable rotator cuff. And is everything that we are proposing today something rational, and is there a lot of science behind it? So what about the definition? I love the work that has been proposed by Ant Brunner and Christian Gerber. And it's not because I'm Swiss. I think it's because there is some science behind it. It's just a review of the literature. So it's not a review of level 4 studies. It's a true basic science study. And they define the pseudoparalysis as a loss of active anterior forward flexion below 45 degrees. And I will add something, and Ruth talk a little bit about it. And I think this is the key, because the pseudoparalysis can be something transient or it can be chronic. And if you have an acute lesion of the cuff, and I saw one on Monday, the patient was truly pseudoparalytic. But when you look at the MRI that I obtained Tuesday, clearly you just have an isolated supra, and this patient will recover. He will have a surgery because he is young, but otherwise, clearly this patient will have recovered. And you have the chronic pseudoparalysis, and for me, this is something that lasts for 6 months. And if this is associated with an anterior superior escape, as Ruth said, there is no other solution. Okay, the only solution, if the patient wants a surgical solution, is the reverse. And then you have the pseudoparalysis, and in the literature there is a huge mix, meaning that a lot of people are saying that they reverse pseudoparalysis, chronic pseudoparalysis, but actually they just reverse a pseudoparalysis that most of the treatment can solve, as I will show you later on. So what is the problem when you have this massive cough? The problem is the bridge that has been described by Steve Burkhardt. So let's go to the basis. I did during my residency beautiful encounters. I trained with Professor Pierre Hofmeyer, but I also met in Geneva Philippe Collin. Then I went to see Gilles Valchilion. I have been working with Steve Burkhardt in San Antonio. I visited 8 US centers in 2012 with Nicolas Bonvial. And finally, I did a short but very useful fellowship in Zurich with Christian Gerber. And amazingly, all this guy has been working on the definition of the pseudoparalysis. And this is a famous article from Philippe in the GSES. He divided the curve into 5 parts, and there is a clear reason for this. The first one is that the teres minor is a forgotten muscle, and we also forget for a while the inferior subscapularis. What is the definition of a massive? Christian Gerber said that it's at least complete tendon. However, today, to complete tendon is something that is not anymore difficult. And this is why we add with Philippe 3D connotation with the retraction of at least one of the tendon above the human head or beyond the human head. So this is for me the definition of a massive. And when you have defined your massive, then you can subclassify your massive into A, B, C, D, E. So A is a posterior anterior-superior, the B, the complete anterior-superior, C, upper subscap, supra-infra, the D is supra-infra, and the E, supra-infra, and teres minor. And why is it very important? Because it will absolutely dictate the way you will rehab your patient. So when we know what is a massive, then we need to define an irreparable. And this is the definition of an irreparable rotator cuff. You need to have a chronic acromion distance below 7 millimeters, a grade 3 or 4 fat infiltration, a positive tangent sign or the backbone fish sign. You can have an anterior-superior escape. And again, the only solution is then the reverse. And you will find also acetabilization of the acromion and formalization of the human head. So this is all the sign that when you look at an X-ray or at an MRI, will make you think that you won't be able to repair this cuff. So let's just go back quickly to the teres minor. It's one of the forgotten muscle. And interestingly, when you have a posterior superior cuff, you have an hypertrophy in not all cases. Actually, it's not so frequent. And interestingly as well, there is a less than anticipated correlation involvement of the teres minor and loss of active external rotation, meaning that in the study that we published with Philippe in the core in 2015, we found that only 33% of E-type that don't have, by definition, teres minor had a clear. So this is quite interesting, and it means that it's not because you have no teres minor that you need to think about a transfer, because it's not always necessary. And then let's go back to the anterior part of the cup, the subscap minor. It's another forgotten tendon. And interestingly, and you see it on the graph, it's really the key for anterior forward flexion. If you have a subscap, a good subscap minor, you will have a good anterior forward flexion. If you have a bad subscap minor, the anterior forward flexion will be bad. So what is really important is to restore this bridge, so to have a good teres minor, a good subscap minor. And if you have so, in most of the case, you don't have pseudoparalysis. And this is the most important slide of tonight. If you have a patient that has a true chronic pseudoparalysis, a B type, it's absolutely useless to say to this patient, "Sir, you should try physiotherapy," because physiotherapy will fail in 80% of the cases. And if you have a D type, don't say to your patient, I'm going to do a superior capsular reconstruction, because whatever you do, this patient will recover a good function without any kind of surgery. Last point is the prevalence of this massive rotator cuff tear. You find massive in 10 to 40% of the rippers, of the tears, excuse me, and 80% of these lesions are D-type. So when we talk about E-types that lost external rotation, we are talking about 15 to 20% of 10 to 40% of the rotator cuff tears. Okay, so this is not so important. So take-home message number one, there is few massive or irreparable rotator cuff tear that involve teres minor and subscap minor. So horizontal imbalance is rare, and consequently, conservative treatment is, in most of the cases, effective. But it can fail. And then when it fails, we have a problem, because the treatment that will be proposed to your patient depends on the place where you live. If you are close to Bassem, you will have a low trap, or maybe close to Toulouse. If you are in Lyon, you will just have a tenotomy, Zurich, a latissimus dorsi transfer, and so on, and so on, and so on. You can also have reverse superior capsular reconstruction if you are in Japan, and so on. So a lot of treatment that depend on the geography, surgeon experience, healthcare system reimbursement, implant cost, and conflict of interest. This is already quite old study, but we try in this study, published in E4 Open Reviews, to summarize the literature for you. It's only level 4, but you have to know that, to the best of my knowledge, we only have level 4, or all level 3 that has been published, or level 3 to 1, because the balloon study is a level 1 study, doesn't show any difference between the gold standard and the treatment that has been compared. So have a look to this graph. Whatever you do, you start with a mean preoperative score that is around 40, except for the reverse that is a little bit lower. Okay, and then you always end at around 75, something like this, except for the reverse, but you start from 20, so it's a little bit normal. But the rate of radiological failure is completely different. It can be between 0 to 100%. So whatever you do at the end, result is amazing, just amazing. And this is why we came with this treatment paradigm. And I'm sorry, it's quite written in small, but on the left of the graph, you will have the massive rotator cuff tear with pseudoparalysis. And I'm talking about, it's not true pseudoparalysis, it's acute pseudoparalysis or pseudoparesis. So if you have on your left an elderly patient with 2 tendon disfigurement or D-type lesion, you should do clearly a conservative treatment. Why? Because this patient will recover, and Ruth published this very nice study and found that the unsuccessful response to physiotherapy are an anterior forward flexion below 50 degrees. Remember, this is the definition of the pseudoparalysis. A complete tear of the subscap. Remember the study of Philippe Collin. A lack of teres minor hypertrophy. I also show you an example. Glenohumeral osteoarthritis. That is, for me, a contraindication to all kind of surgery except the reverse. Stiffness, like Jean showed you nicely, and weakness of external rotation or abduction. This is rare. So we decided to follow a patient with a D-type lesion for at least 2 years with Philippe Collin. And what we did, we relieved the pain, we correct faulty humeral head centering, we strengthened the muscle that stabilizes and moves the shoulder with the arm elevated, because we think that the deltoid is working better in this position. I know that Levy from England does not agree with this concept. And we also work on the recovery of proprioception and movement automatism. So we had this protocol. All the patient has been prospectively included. It was not comparative. It was a prospective study. And we had 45 patients with pseudoparalysis. And at the end, 93% of the D-type recover more than 160 degrees of anterior forward flexion at 2 years, and with a 0 complication rate. This is quite nice. So I think it's the non-surgical option for this patient is elegant, because as most of these patients don't have posterior superior escape, they respond favorably to non-surgical treatment. So this should be tried at least during 6 months before considering a reverse. And then we have the patients that are not old, they are quite young. They have a massive cuff tear, 3 tendons, ABC lesion. And this is something that is repairable. And this can be an acute or chronic. So in the study that we published with Patrick Donald, most of the case was acute pseudoparalysis. In this case, clearly you should do simply a repair. So this is what we did, publishing the AGSM in 2015. And 51 patients, 90% of them recover from the pseudoparalysis. If it was primary cases, the percentage is clearly lower if it's a revision. And interestingly, I look at the 21 cases that I collected for this study, and all the acute and chronic healed the acute part, but the chronic part never healed. But as I allowed some kind of healing, I rebalanced the shoulder and the patient recovered. And then you have the patient of Ruth. I think that reverse plus minus a latissimus dorsi transfer or lepiscopo or low trap is an option for this elderly person that has bone loss, or for this patient that has non-repairable or only partially repairable rotator cuff. And I just would like to add one column, because a few people are talking about this, and I think it's very interesting. I face from time to time, and since 2011, I only operated 8 patients, so it's not so much. You patient that has proximal humeral bone loss, and I tried to repair this patient, so to repair the cuff in the bone defect, and it never worked. So this is why I came with this idea to reconstruct the bone with the calcaneum, and then use the Achilles tendon to reconstruct or to reinforce the remaining rotator cuff. And I had some good result in patients that didn't find in primary surgery. In revision cases, I have been deceived, and I had to revise 2 patients. So take home message, I still trust the gold standard. That is for me the conservative treatment for pseudoparalysis or pseudoparalysis or chronic pseudoparalysis with ABC type. If this failed and the biceps is intact, as Jean, I propose a partial repair and a superior capsular reconstruction. Why? Because this is inexpensive, safe, and unbiased. And if you don't have any biceps, you can try the superior capsular reconstruction. You can try and transfer. But I think that you need to be honest with your patient, and you need to warn them that there is little scientific proofs. There is a consequent radiological failure rate. It's above 50%. And this kind of surgery compromise subsequent surgeries. So this is why if I face this kind of patient, I go straight for the reverse. And last slide, I just would like to show you something. I love Harari, and Harari told me that humans were always better, far better at inventing tools than using them wisely. And I'm Swiss, so of course I'm rich, but I am what I consider a rich poor, because this is the amount that I have to pay every year to cover my family with a private insurance. Okay, 33,000 euro to cover my family. And we are all responsible for this. And this is why from time to time, we should be reasonable. Thank you for your attention.
Thank you very much, Alex, for your very, very interesting presentation. As you say, it was a comprehensive summary of the webinar. So that was amazing. We really have only few minutes for the discussion. I can see there are some question in the question and answer, so we can answer through the chat. And just to talk a little bit, I would like to break the ice with a question for everyone. So is conservative treatment the first option for all of your patients? In my practice, the answer is no, because usually I don't start with a conservative treatment with all pseudoparalytic patients, but please let me know what you do.
No, I want to be clear. I always favor it and prefer the conservative treatment. But after 6 months, 1 year or 2 years, when it fails, because Alex said it works very well, I think after 1 or 2 years it can fail just because of aging. So the goal of just in 1 minute, the goal of the conservative treatment is to rebalance the subscap and the teres minor, because these are the two good muscles. So you try to have something thicker, but how long does it work? And with aging, we know that we have all an atrophy of all the muscle of the body. So after a while, it cannot work. I'm sorry, it cannot work after a while. And the tendon transfer is just here to augment one of the two of these two muscles. This is just I want to say. But the conservative treatment is the rule for sure at the beginning.
I think it depends also, though, on the individual patient. I have a concern in a younger patient with losing that window of opportunity. If they're more acutely pseudoparalytic and they're going to do well with a tendon transfer or an SCR, if I try conservative management and they do well for a while, but then they come back and they're chronically pseudoparalytic, or I try conservative management and it's not working, you know, I've lost maybe that window of opportunity to preserve their shoulder joint, because even though I said, okay, with the reverse, we're more comfortable now with younger patients, I don't want a 45-year-old or a 50-year-old patient to be left with the only option of reverse. So I think there are some situations where conservative management isn't the first line. It depends really on the individual patient. And for me, a lot is their age and activity levels as to whether we try conservative or not first.
Ruth, may I ask you a question regarding your technique of doing superior capsule reconstruction, because you have some experience with using dermograft? There are more and more reports on the results using long head of the biceps. What are your thoughts about long head of the biceps?
I think it's interesting. And of course, there are advantages, you know, in terms of cost and availability. I don't have much experience with using that. I suppose when you see that nasty degenerative biceps that's a source of pain, to me, it didn't intuitively make sense that it could be useful or could be trusted. But the literature is showing more promising results from that. I think, you know, with the SCR, we've had very good results. I accept that there are failures. If you go and MRI them, there are some failures radiologically. But we found that what we were using, what's available here is actually the porcine xenograft, and you double it over, so you make a thicker graft. It's not even the human one they have in the US. But we've, in the right patients, had good results. I've become more hesitant to select it, though, for pseudoparalytic patients because of the results that I showed. So I think it seems to function as really like a cross between like a partial repair, because you are repairing partially the posterior cuff as well, and you're rebalancing the shoulder. And whether it's just acting like a temporary spacer like the balloon, then, you know, I'm not sure, because the radiological failure on the MRI didn't correlate with clinical failures. So maybe it doesn't work the way we think it works.
And Jean, you talk about the possibility of doing a combined tendon transfer plus a long head of the biceps, superior capsule reconstruction. What do you do in your patient when there's no biceps? Do you use something different?
Thank you, Emilio. When there is no biceps, I don't use the bicep for sure. I just do my tendon transfer because there is no bicep. But so far, I've never used or tried the lat dorsi plus a fasciculata. It's a very long surgery, so I don't want to try that. Thank you for this question, Emilio.
Another challenging question: if you have a pseudoparalytic shoulder in a patient who already undergone a rotator cuff repair, so it's a retear, I would say a traumatic retear. You have a pseudoparalytic shoulder in a traumatic retear. Would you consider joint preserving options or rotator cuff revision or whatever, augmentation or whatever, or you go straight forward to the reverse? All the faculty. Jean. I know you love to start. Go.
Okay, so in case of repair, I do not try to repair again because it failed once. I am not better than my friend, especially if it's a long time ago. I consider first tendon transfer, or if it's not possible, I consider reverse for sure.
So it's funny because I do 2 revisions today. And its patient, one of the patient has been operated in 2008 very well. He had a new fall, and this is typically very young, and this is typically somebody that I would repair. I won't even discuss about a reverse in this patient. But for a patient that will be above the age of 60, I will discuss about a reverse. And I have today a prospective comparative study for massive repair versus reverse. Quite difficult to include patient, but I will continue.
I think I have a similar philosophy to Jean. When I see a failure of a cuff, I don't trust that cuff to heal again, even if the failure has a clearly explainable reason, like a trauma. You know, I feel that I need to do something else. I need to, even if I can repair it, I'll augment it with perhaps the DX matrix in a single layer over it, or, you know, some people will augment it with biceps, but I think it's, I want to give it some extra help. If it's a revision repair, I won't go straight to reverse if it's a younger patient, like Alex just said. In some situations, that's the appropriate thing to consider, but I don't just re-repair it.
Maristella, I have some experience in repairing a post-operative rotator cuff.
No, I didn't do revision repair, but like the others say, I try to augment the repair, maybe a partial repair, but then I do SCR with semitendinosus or allograft and tendon transfer if needed.
Interesting, because we published a series of patients with a revision rotator cuff repair with good results, but it's only to be preserved for young patients with small tears. Otherwise, it's better to do a reverse arthroplasty. And in my experience, in contrast to Kany, the results of tendon transfers after failed rotator cuff repair have not been very good.
And Emilio, you used, if I remember one of your presentation, you do it from time to time open, and this is something that I do as well.
Yeah,
I do not hesitate.
Yeah. Okay, I think we are behind the schedule, so we need to close this very interesting webinar. So thank you to all participants to prepare the presentations. Thank you to Maristella for chairing the session with me. So thank you very much.
Let's see at SECEC.
Okay.
Okay.
Thank you. Enjoy your summer. Bye-bye.
Bye.
Bye-bye. Bye.
Thank you. Good night.